Dear students, today we are going to discuss the PAUCI immune glomerulonephritis. The PAUCI immune glomerulonephritis is the most common crescentic glomerulonephritis. In PAUCI immune glomerulonephritis, ANCA is present in 85% of the cases. And this is predominantly is found in old patients and there is a male predominance. Actually, the PAUCI immune glomerulonephritis, when we talk about the clinical subtypes, there are mainly three clinical subtypes of this disease. Number one is the microscopic polyangiitis. When we talk about the microscopic polyangiitis, the histological feature of microscopic polyangiitis is necrotizing vasculitis without any granulomatous inflammation. So, microscopic polyangiitis, when we see the histological feature, this is the necrotizing vasculitis without any granulomatous inflammation. This is called the microscopic polyangiitis histological feature. ANCA is present in 60% of the microscopic polyangiitis, that is called the MPO, myeloperoxidase, or we can say the P-ANCA. P-ANCA is present in 60% cases, and this is the feature of microscopic polyangiitis. The second clinical subtype is the granulomatous polyangiitis. Granulomatous polyangiitis is basically necrotizing vasculitis with granulomatous inflammation, and mainly the kidney and the lungs are involved. When we talk about the anti-neutrophilic cytoplasmic antibodies, so 70% PR3 are positive, and you can say the C-ANCA is positive in 75% of the cases. So this is the histological subtype. The second histological subtype, which we call the JPA or Wegener's disease, granulomatous polyangiitis. The third one is eosinophilic granulomatous polyangiitis. The other name of this disease is the Churg-Strauss syndrome or Churg-Strauss disease. Churg-Strauss disease is basically, when we see the histological feature of this clinical subtypes of the disease, there are eosinophilic rich necrotizing granulomatous inflammation. Eosinophils rich granulomatous inflammation, and mainly the lungs, and in 50% of the cases the kidneys are involved. In 75% the ANCAs are positive if the renal disease is present. So if the renal disease is present in eosinophilic granulomatous polyangiitis or Churg-Strauss disease, the 75% ANCAs are positive. 26% of the ANCAs may be present if there is no any kidney involvement. So these are the clinical subtypes of the PAUCI immune glomerulonephritis. Now, what are these ANCAs? The anti-neutrophilic cytoplasmic antibodies. What are these? Basically, the ANCAs, when we perform the immunofluorescence on ethanol fixed human neutrophils which are incubated with patient serum, performing immunofluorescence on ethanol fixed human neutrophils incubated with patient serum, so we find the antibody against PR3, and these are called the C-ANCAs. And if the antibodies are against the MPO, then we call it P-ANCAs. Elevated P-ANCA oblique MPO antibody can be seen with SLE and inflammatory bowel disease also. So these are the ANCAs. So what we do, we perform the immunofluorescence on ethanol fixed human neutrophils, and these are incubated with the patient serum, and we get the antibodies. So if antibodies are against the PR3, we call it C-ANCA. If the antibody against our MPO, we call it P-ANCA. Elevated P-ANCA is also found in with SLE and inflammatory bowel disease also. Now, pathogenesis. What is the pathogenesis? The formation of ANCA may be triggered. The formation of ANCA may be triggered by several mechanisms. And what are the mechanisms? These mechanisms may be environmental stimuli, this may be drugs, and this may be some infection, molecular mimicry, epigenetic dysregulation may be there, and loss of T cell regulation. So these factors basically can predispose to these ANCA formation and may lead to this pathogenesis. So this is about the pathogenesis. So what we have discussed the PAUCI immunoglomerulonephritis is the most common crescentic glomerulonephritis. ANCAs are present in 85% of the cases. This is the male predominant disease, and basically the old patients are usually affected. And when we talk about the clinical subtypes are mainly of three: the microscopic polyangiitis, number one, and the histological feature is the necrotizing vasculitis without granulomatous inflammation. 60% MPO are present. The second one is this Wegener's disease or granulomatous polyangiitis. This is the necrotizing vasculitis with granulomatous inflammation. Kidney and the lungs are involved, and 75% cases PR3 or CNK are present. The third one is eosinophilic granulomatous polyangiitis, which we call the Churg-Strauss disease. This is the eosinophilic rich necrotizing granulomatous inflammation. Usually lung and kidney and half cases of the kidney are involved. In 75% cases, the ANCA is present if the kidney is involved, and in 26% of the cases, ANCA are present if lungs are involved. So these are the clinical subtypes. What are the ANCAs? ANCAs are performing immunofluorescence on ethanol fixed human neutrophil incubated with the patient serum, and we get the antibodies. And if it is against the PR3, we call it CNK. If it is against the MPO, we call it PNK. So what is the pathogenesis? The pathogenesis, the formation of the ANCA may be triggered by several mechanisms, like maybe because of the infection, maybe because of the environmental stimuli, maybe some epigenetic dysregulation, maybe the loss of T cell regulation, molecular mimicry, drugs are etc. responsible for this, the pathogenesis of the disease. So we have discussed the pathogenesis. Now we come to the mechanism of vasculitis. How vasculitis develops? Actually, what happens when there is the activation of the neutrophils by Fc receptors? Activation of the neutrophils by Fc receptors. There is the release of some kind of substances which we call NETs, neutrophil extracellular traps substances. Neutrophil extracellular trap substances, and these contain chromatin and granules. And these proteins, basically these granules, chromatins, damage to the endothelial cells. So what happens? Activation of the neutrophils by Fc receptors, release of the NETs, and NETs is responsible. NETs contains basically the chromatin, the protein, the granules, and these are responsible for the damage of the endothelial cells. And this damage of the endothelial cells, these are antigens presentation to the immune system. These are presented to the immune system, and there is the activation of the complement pathway. So this is the mechanism how vasculitis develops. Now, what is the pathology? How we define the pathology of the disease? When we see in the light microscopy, there is, as we discussed, there will be the fibroid necrosis of the glomerular tubes, and there may or may not be the rupture of the glomerular vascular membrane. So there may be the fibroid necrosis of the glomerular tuft. There may be the rupture of the glomerular GBM, or there may not be the rupture of the GBM. Proliferation of the epithelial cells may be there, and these are called the crescents. So proliferation of the epithelial cells occurs, and there is formation of the crescents. When we see in the light microscopy, these features are seen usually. When we see the IF, immunofluorescence, no staining for IgG, mild complement staining is sometimes seen. So there is no staining for Ig, and there is no staining for immunoglobulins at all, and there may be the complement staining. There may be the complement staining sometimes, but not always. When we see in electron microscopy, there are no any electron dense deposits are found. So this is the pathology. So we have discussed the mechanism of vasculitis, we have discussed the pathology. Now, what are the clinical features? What are the clinical features? When we talk about the clinical features of the PAUCI immunoglomerulonephritis, these may be number one, constitutional. The constitutional features may be as everybody knows, maybe the malaise, fatigue, fever, weight loss, night sweats, etc. These may be the constitutional symptoms. Renal symptoms, there will be the RPGN, rapidly progressive glomerulonephritis is the main characteristic maybe of this disease, and will lead to AKI, hypertension, edema, maybe the hematuria, subnephrotic ring proteinuria. So if we see the clinical feature related to the kidney, so these presentation may occur. So constitutional symptoms, renal, what happens to the lungs, pulmonary, the pulmonary features may be the hematosis, maybe the cough, maybe the dyspnea on exertion, maybe the alveolar hemorrhages or infiltrates. So these may be there, pulmonary infiltrates may be there may be the cough, there may be the dyspnea on exertion, there may be the hematosis. Now the features related to the sinonasal, there may be the sinusitis, there may be the otitis media, saddle nose deformity may be present. When we talk about the dermatological symptoms, there may be the purpura, petechiae, ulcers, there may be the urticaria, ecchymosis, and there may be the bullying. So these are the dermatological features may present with the disease. Ocular symptoms may be like iritis, uveitis, and episcleritis. When we talk about the gastrointestinal symptoms, there may be the bleeding or perforation due to the vasculitis. Maybe the perforation due to the vasculitis. Neurological symptoms may present in the form of mononeuritis multiplex and cranial nerve palsies or cranial nerve abnormalities. So these are the clinical features. Number 1, constitutional symptoms. Number 2, renal may be the RPGN, AKI, hypertension, edema, hematuria, maybe the subnephrotic range proteinuria. Pulmonary means hematosis, cough, dyspnea on exertion, or maybe alveolar infiltrates. Sinonasal, sinusitis, otitis media, saddle nose deformity may be there. Dermatological, there may be the purpura, petechiae, bully, and there may be some ecchymosis. Ocular, the ocular symptoms may be iritis, uveitis, episcleritis. GI, there may be the bleeding or there may be the perforation because of the vasculitis. And when we talk about the neurological symptoms, there may be the mononeuritis, multiplex, or cranial nerve deformities. So these are the clinical features. Now we go to the specific disease in terms of the clinical features. When we talk about the PR3 disease, the clinical feature related to PR3 disease may be the saddle nose deformity, maybe the nose ulcers, maybe epistaxis, hearing loss, lungs with cavities. If we talk about the MPO in terms of the clinical features, MPO disease, so this is the renal limited basically glomerulonephritis, and lung involvement without nodule or without ENT issue may be there. So when we talk about the clinical feature, if we talk about the PR3 disease, there is maybe the involvement of the eye, nose, throat, there may be the involvement of the lungs, and but when we talk about the MPO disease, so this is the renal limited glomerulonephritis. If we talk about the pathology of the PR3 disease, so this is the focal glomerulonephritis basically, and necrosis is over there. And in MPO disease, there is the global sclerosis, there may be the interstitial fibrosis. And what about the recurrence? PR3 disease is more frequent than MPO disease. So these are the differentiating feature of the PR3 disease and the MPO disease. Differentiating feature in terms of the number 1 clinical feature, in terms of number 2 the pathology, in terms of number 3 recurrence. So in terms of the clinical feature, if we talk about the PR3 disease, there is the saddle nose deformity, means nose involvement, there may be the nose ulcer, there may be the epistaxis, there may be the hearing loss, there may be the lungs and lungs with cavities. So these are the basically PR3 disease related clinical feature. But when we talk about the MPO disease, so this is the basically renal limited disease, and without the lung involvement, without nodules, without ENT issues, without any lung involvement. So this is the MPO disease in terms of the clinical feature. If we distinguish the pathology, so basically there is in PR3 disease there is the focal glomerulonephritis and necrosis, but in MPO disease there is glomerular sclerosis, global sclerosis and interstitial fibrosis. There is global sclerosis and interstitial fibrosis in terms of the pathology. And when we talk about the recurrence, the PR3 disease is more frequent and MPO disease is less frequent. So these are the distinguishing features of the PR3 disease and the MPO disease. Now, next is workup. What we do to diagnose the disease? What is the workup? How we investigate? What we do? When we see the labs, basically there is increase in creatinine. There may be the increase in creatinine. There may be the dysmorphic RBCs in the urine. There may be the red cell cast in the urine. And when we go for the antibody check, we find the positive P ANCA or C ANCA. So these are the labs which we usually found the findings. Number 2 is we are supposed to rule out the drug-induced causes. Like we are supposed to rule out maybe there are some drugs which are responsible for this disease. Maybe the hydralazine, maybe the allopurinol, maybe the levimazole may responsible for the disease. So we are supposed to rule out that particular drug also, whether it is drug related or not. Now we come to the treatment. What is the treatment? Treatment of the disease. The first is the induction, and when we talk about the induction is the cyclophosphamide with the corticosteroids. And when we talk about the corticosteroid, this is the 1 milligram per kilogram body weight for 1 month and then taper for the 6 months. When we talk about the cyclophosphamide, this is the monthly IV dose or oral. Maybe it may be given, we give the IV then 0.5 to 1 gram per meter square, and dose is adjusted as per the GFR. There is the role of the rituximab, and the rituximab is usually given 375 milligram per meter square weekly into 4 weeks. Beside this, there is the role of the plasmapheresis. We should go for the plasmapheresis for 7 session of the plasmapheresis in 14 days, alternate day. If there is RPGN or there is the pulmonary hemorrhage, then we are supposed to go for the plasmapheresis. So if there is not life-threatening vasculitis, then we also give the MMF. So this is the treatment. And when we after induction, when we get the remission, that there will be the maintenance therapy. So what we give in maintenance therapy, 18 months of maintenance therapy who have remission, we usually give 18 months of remission therapy. No further therapy who have ESRD without extrarenal disease. So we are supposed not to give further therapy who have ESRD without extrarenal disease. Azathioprine, usually 1 to 2 milligram per gram per day for MMF 1 gram BD we can give. So this is the treatment related to the PAUCI glomerulonephritis. So after treatment, now we come to the relapse. What about the relapse? When we talk about the relapse, there are 30 to 50% in 5 years. There are chances if the disease is with the PR3, and relapse is higher with the PR3. Reappearance of the ANCA and increased titers, higher rate of relapse are usually considered. If the ANCA titers are increased, so there are high chances of relapse. If we find the very high titers of ANCA in the beginning and we have treated the disease, so in future there may be the higher chances of the relapse. So if there is persistent hematuria more than 6 months, then maybe the higher chances of the relapse. So when we talk about the rituximab, in cases of the relapse, rituximab is basically considered effective in the cases which have the relapse. When we talk about the transplantation, so in case of the renal transplantation, when we consider the patient for the transplantation, renal transplantation, wait for 1 year after the remission. When once remission has been achieved, we are supposed to wait for the 1 year, and the risk of recurrence is more than 10%, more likely, and in PR3 disease. If there is a PR3 disease, the risk of recurrence is increased. But once there is a remission, we are supposed to wait for the 1 year if we go for the renal transplantation. Now, what is the prognosis? When we talk about the prognosis, the complete remission in 70 to 90% of the cases. If the patient is untreated, there is 80% mortality. So treatment is very important, and there is a complete remission in 70 to 90% of the cases. Pulmonary hemorrhage is the most important determinant of the survival. So pulmonary hemorrhage is the most important determinant of the survival. 20 to 25% will progress to ESRD, and basically biopsy is also the predictors of the prognosis. What is the degree of glomerulosclerosis? What about the intestinal fibrosis? What about the tubular atrophy? So this biopsy predictors or biopsy findings are also important in predicting the prognosis of the disease. So this basically completes the PAUCI immunoglomerulonephritis. I hope you understand.